Ladies and gentlemen, welcome to this meeting of the Board of NHS England. As you know, we meet in public. It's not a public meeting in the sense of audience participation, but very important to us as a board to ensure that the decisions that we take on behalf of the population of England and the patients of the NHS are taken in public and seen to be taken in public. As I so often say on these occasions, these are not the only meetings that we have. We spend quite a lot of time as a board involved in thinking through strategy for the future and developing strategy. We always have to have a private meeting in which we take business that, for statutory reasons, we can't take in a public meeting. But we are determined as an organisation to bring into the public domain the big decisions that we have to take, and many of those are on today's agenda, particularly following the discussions that we had at the November meeting, following the November budget. So we'll come to those in a moment. So a very warm welcome to everybody to the meeting, which I now formally open. First, to report that I have apologies today from Moira Gibb and from Victor Adbawali. Secondly, to warmly welcome to the meeting Professor Steve Powers, who is our new National Medical Director in succession to Sir Bruce Keogh. Steve, welcome to this, your first formal meeting of the board. To report that there is no fire alarm scheduled, no fire alarm test scheduled through the course of this meeting. In fact, we had it about an hour and a half ago, so that if the alarm does go off, we will ensure that everybody is safely escorted from the building. So let me then move on to the formal business of the meeting, the first of which is to invite the board to make any declarations of interest in any of the items on the agenda over and above the declarations that we already hold on file. And Steve Powers has just handed me his new formal declarations of interest, which will go into our register. Are there any other declarations? No? Okay, thank you. The minutes of the last meeting have been circulated. May I invite colleagues to approve those minutes as a fair and accurate record, and invite any comments on whether there are any issues arising. I don't have any issues arising, so we'll take those as a record and move on. The next item on the agenda is the Chairman's report. I have on this occasion filed a written report, and I would simply want to invite the board to draw their attention to two or three issues. The first is the award of honours, for which I think we can express appropriate appreciation on the part of the board, and amongst them to Paul Baumann, who is, of course, our Chief Financial Officer, who so frequently leads us through the dark valleys of ignorance and despair into the sunny uplands of financial comprehension. I'll pass on quite quickly. The second area that I want to draw particular attention to is our working relationship with NHS Improvement. And this is something to which Dido Harding, the new chair of NHS Improvement, and I have determined we should devote considerable attention to, not just in terms of continuing an existing relationship between two quite separate organisations, but trying to understand how we can deliver better value for the patients and population of England by drawing the organisations closer together, how we can cut out inefficiencies, and I think even more critically, how we can overcome a phenomenon of giving two different versions of the truth when we're out in the field and dealing with NHS organisations. So we're both conscious of this. Neither of us believes that this is going to be an easy process, but we are determined to take from today some very important first steps towards drawing the organisations more closely together in our operational terms. We don't have the option of merging the organisations, so we have to try to understand how we can simplify our operations to the benefit of the service as a whole. Something that we have agreed upon is that we should make, first of all, a cross-appointment of non-executive director from each of our boards to the other. At their recent meeting in January, NHS Improvement Board approved the appointment to their board as an associate director in the first instance of David Roberts. I'm very grateful to David for taking on this additional responsibility, but I'm sure it will help to bring the work of the two boards more closely together. I invite today this board to approve the appointment on a reciprocal basis of Richard Douglas from the NHSI board to become an associate member of this board. Now, I use the word associate deliberately because what we're talking about is not a formal full appointment as a non-executive director, because that is not at the moment permitted under subordinate legislation. But in the anticipation that the subordinate legislation can be amended, I would anticipate that the Secretary of State could then move quite smoothly to making a formal appointment and securing the relationship that we wish to achieve across the two organisations. And in my report I refer to the issue of conflicts of interest. Clearly, private conflicts of interest arise at any time in any board, are dealt with through a process of declaration and, if necessary, a recusal from participation in items of business. But what's particularly important to note in this context is the phenomenon of institutional conflict of interest. In other words, there are aspects of business of NHSI which are potentially in conflict with aspects of business of NHSE, particularly those regulatory functions. I've listed 2 or 3 of those areas in the report, but there will be others, no doubt, that will crop up from time to time, and we'll need to make sure that there is no conflict between the two organisations. So can I just, first of all, invite the board to approve those cross-appointments? Then, secondly, I'd like to draw the attention of the board to committee realignments within NHS England. I'm very grateful to Wendy Becker for agreeing to step up to take on the chairmanship of the commissioning committee, but we'll just ask you to note that the date we would prefer to adapt to the 1st of April rather than the 10th of February for that. And in the meantime, David Roberts has agreed to continue chairing the commissioning committee. If you're content to approve that and the other proposals for changes to committee membership, I'd be grateful. Thank you very much. So that's the end of the Chairman's report. I'm happy to take any questions or comments. Right, thank you. I shall move on then, please, to the Chief Executive's report. Simon, over to you.
Thank you, Malcolm. I think most of our business is on the agenda, so I would just really draw attention to all of the work that's been going on right across the health service since we last met over the very busy winter period. I think it is well known the pressures that have been experienced, the fact that we've had the worst flu season since the pandemic 7 years ago, the hospitalisation rate for flu 3 times higher than last year. That has obviously put particular pressures on certain parts of the country. Nevertheless, it is therefore particularly gratifying that despite all that, the figures published at 9:30 this morning show that hospitals in fact managed better A&E performance this January than they did in December or indeed a year ago last January. That I think is a huge tribute to the response of many staff right across the health service. I've seen this firsthand, having taken the opportunity to spend evenings and Sundays in some of our most pressurised parts of the NHS since we last met, whether that be Staffordshire, Portsmouth, North East London, and shortly East Kent. So I can tell you that, as we've heard from Pauline previously, people have really gone the extra mile over this holiday period. There is no contradiction between saying that the NHS was indeed as prepared as it could be, while also acknowledging that the pressures that have been experienced are very real indeed. So I think as a board we should place on record our thanks to staff right across the health and indeed social care system for their work over the last several months.
Indeed. We shall certainly do that. Any comments, queries on Simon's report? As he says, much of the business that he would otherwise report on is substantive business on our agenda today. Right, thank you very much. May we move then, please, to item 4 on the agenda, which is planning guidance and finance allocations. Simon, may I invite you to introduce this paper?
Thank you. Yes, so as the paper records, this is in 2 parts. Firstly, to note the fact that we have agreed and issued planning guidance jointly with NHS Improvement for the year ahead. The reason we're noting that is that is guidance that is in line with the board-approved 2-year set of deliverables that we set out in the next steps on the forward view last March, and it accords with the principles that we discussed publicly at our board meeting at the end of November. So I will just briefly recap what that means for the service improvements and priorities for next year, and then Paul will take you through the second part of it, which is the actual formal decisions that the board's got to make in terms of allocating the money. So we, since we're last together, have now got £2.14 billion worth of funding to allocate. That's another 540 million in addition to the 1.6 billion that was agreed at the budget time. This follows constructive discussions between ourselves, the Department of Health, the Treasury, and NHS Improvement. And on the back of that, we have been able to work our way through the 5 guiding principles that we discussed. Firstly, ensuring that just over £1 billion of extra funding next year will be allocated, subject to the decisions we make in the next part, to both trusts and CCGs to support unfunded costs of care that are already being delivered. Secondly, a shared ambition with NHS Improvement to set realistic plans for next year about the level of emergency activity in the system. As I think Matthew will describe in his report, actually there are some sort of interesting nuances and complexities to that, in that actually the NHS has been doing a good job locally in constraining growth in emergency admissions that require overnight stays in hospital. Those numbers have been going up around about 1%. And actually the number of NHS-related delayed transfers of care, the figures published this morning at 9:30 show, are now the lowest they've been in 4 years. So good work on that front, but nevertheless we want to go in to next year with realistic local plans for emergency activity, and we're funding CCGs to do that. Thirdly, we were very clear at our meeting at the end of November that we did not think it would be acceptable to balance the NHS's books on the back of mental health services, cancer services or primary care services next year. And I'm very pleased that we are able to fully fund the deliverables, the improvements for 18-19 that were set out in the Next Steps document. And in particular, we are taking for the first time, I think, ever in the history of the NHS, a very clear-cut approach to mental health services investment growth, and we're going to require every CCG next year to ensure that its own investment in mental health services goes up faster than its overall funding growth, and that will be subject to independent audit for each and every CCG. That is a sort of additional commitment over and above ensuring that at the national level, in aggregate, mental health investment goes up faster than overall NHS funding growth, a commitment that we are confident will have been met this year, as indeed it was last year in 2016-17. But obviously investment is there for a purpose, and the purpose is to expand the full range of services, be they child and adolescent mental health services, perinatal, talking therapies embedded in primary care, and a range of other crisis and liaison psychiatry investments set out in the Mental Health Taskforce. Similar approach on cancer to delivering the improvements that were set out in the Cancer Task Force. By October of this year, we should have completed the biggest upgrade in precision radiotherapy cancer treatments with the new Linacs that we've had in over 15 years, as well as making further gains in building capacity for fast diagnosis, which I think we will talk in the context of Michelle's report on later on in the agenda, particularly in inequalities focus there, and on primary care, using the extra investment which is going in to continue to bring together practices as primary care networks serving the 30 to 50,000 populations, which really are the foundation for a stronger out-of-hospital system in the way that most parts of the country have recognised, in fact really all parts of the country have recognised is now required. So we can talk about those in any detail required, Malcolm, but the deliverables are all set out in the annex to the planning guidance. And then above and beyond that, I suppose one of the things that has changed since we discussed at the end of November is that partly as a result of the extra budget, the extra 540 million of purchasing power which we have at our disposal, it will be possible to fund a bigger increase in elective activity waiting list operations next year than the NHS has been able to afford for the last 3 or 4 years. And we are therefore asking local CCGs and their trusts to plan for stabilising and, where possible, improving the overall waiting list position while at least halving nationally the number of patients waiting more than 52 weeks, which is a small number. It's under 2,000 relative to the millions of people who are looked after every year, but nevertheless, that's something we want to make sure does not grow or get out of hand. And then lastly, we set out the principle that additional pay for frontline NHS staff would need to be funded separately, and that was a principle that has been accepted by government. So that's not a call on the 2.14 billion that Paul is going to describe to you now in terms of how we're seeking to allocate the funding for next year. So I think good progress made since November 30th, strong alignment with NHS improvement, a lot of work to be done now locally across the NHS to refresh the 2-year plans that people already have in train, not starting from a blank sheet of paper, but nevertheless wanted to get to a position where by the time we meet at the end of March, we've got a good line of sight to what the combined efforts of the whole of the NHS will mean for patients for next year.
Thank you, Simon. Paul.
Thank you, Simon. So today's attempt to lead you through the veil of ignorance, as you put it, begins at the top of page 4 of the cover paper for planning and allocations that you have in front of you. From paragraph 8 of that paper onwards, we set out the proposals with regards to resource allocation to support the planning approach that Simon has just talked us through. And I'll take you briefly through the key points, highlighting as I do so each of the decisions which I need you to take today to enable the system to get on with the critical task of planning and delivery in line with the priorities that we've set. Paragraph 9 confirms that with the welcome addition of 2.1 billion of additional resource, which Simon has just mentioned, we now have 113.9 billion to make available to the system for 18-19, which is equivalent to 1.4% in real growth once age-weighted population growth is taken into account. So it's indeed a very welcome and necessary injection of additional resource, but as paragraph 10 points out, it still leaves all health economies with a very substantial efficiency challenge, which is set out in greater detail in the planning guidance, which you've also had available to read. We've already distributed 111.8 billion of that funding in the decisions that we took back in December 2015, so it's mainly the deployment of the additional 2.1 billion on which we need to take active decisions today. The bulk of the resource, as you can see towards the bottom of the page, naturally goes to CCGs as the commissioners of most services across the NHS, and the 1.4 billion referred to in paragraph 12 is designed to enable CCGs to give effect to the priorities set out in the first half of the report, and which Simon described in his introduction. We've costed the financial impact of the activity growth rates and other investments required to do those key priorities, to make realistic plans for emergency care, to honour our commitment to prioritise improvement in mental health services, to halt the growth in elective waiting lists, and to cover the other routine pressures facing CCGs. The key assumptions underpinning all of that are set out in Appendix A to this paper. I wasn't going to take you through line by line Appendix A, but there is a small prize at the end of the board paper for anyone who has spotted the one numerical typo in Appendix A. So that's something for you to do if you get bored with the rest of what I've got to say to you. Taking all of those assumptions together, CCGs will require just under £1 billion on top of the 1.5 billion funding growth we allocated to them back in 2015. And this purchasing power will be given to all CCGs through the measures set out in the first 2 bullets of paragraph 12. Firstly, we will be scrapping the requirement for CCGs to set aside 0.5% as a system reserve, which frees up around about 370 million to help fund the pressures that I've just described. We're able, by the way, to operate without a system reserve next year because, as I'll make clear in a moment, we are fully funding through other means the deficits for which that reserve has substantially been used in the last couple of years. The remaining 600 million of required purchasing power will come in the form of an additional allocation to CCGs, which we're planning to distribute on a simple fair shares basis to ensure that all health economies have the means to cover the pressures that they will be facing. You might ask, why are we not doing more redistribution of allocations as we did back in 2015? The answer to that is twofold, one of which is that we did all the redistribution back in 2015 that we intended to do. They were fine judgments at the time, and I think those judgments have stood the test of time. And secondly, if we start differentiating the amount of cover that CCGs have got to face pressures that every CCG will face for the coming year, I think we make life much more complicated in terms of having success in the planning round, but we may wish to discuss that particular point later. So that's the first proposal, those two decisions to release the system reserve and more particularly to make an allocation of 600 million to CCGs. That's the first decision for which we need your approval. I was going to go, Malcolm, through all of the decisions and then come back at the end of that to
we should take
make them, if that's okay. But the detail of all of that is set out in paragraph 17 to 21, if you like it. By the way, the technical updates in those paragraphs to the target allocation formula are relatively minor in nature, which is why I'm not discussing them today. We haven't taken a major look at the structure of CCG target allocations. We agreed in 2015 the next time we do that would be with the 1920 onwards allocation. So these are technical updates rather than a major revision to the formulae. You will also see in paragraph 21 that we have honoured our commitment to ensure that no CCG is more than 5% below its target allocation, which has required a small amount of additional funding for one CCG that would otherwise have come out of that zone. So that's the first topic. Second topic is the introduction of a Commissioner Sustainability Fund, which is designed to give all CCGs the chance of delivering a balanced plan next year and to provide, perhaps more importantly, a powerful incentive for the most challenged CCGs to set and deliver stretching improvement targets to minimise their drain on national resources. There are around 50 CCGs who are implementing recovery plans to eliminate a structural operating deficit over time, but where our assessment indicates that even with stringent measures to close the gap, it'll take longer than 1 year to do so, we need to do something a bit different in 1819. Rather than leaving them to continue to rack up ever bigger cumulative deficits, some of which are now reaching proportions which mean they have little chance of repaying them over any reasonable period, we're proposing to provide non-recurrent funding equivalent to the in-year deficit in 1819, where the CCGs concerned sign up to and then critically deliver a control total for accelerated recovery, which we have set for them. We've set aside 400 million for that purpose and will work with these CCGs to ensure that they construct credible plans to deliver the control totals that we've set for them. The reward for the CCGs concerned is perhaps obvious. They stop adding to the amount they'll need to repay once they get back into financial balance. But it's important to state there's also a benefit for the other CCGs and for the system more broadly, in that the amount of national resource consumed by the most challenged CCGs will be minimised through the incentive that we're offering them to stretch themselves to better performance, which means that over time there will be more money for both routine allocations and drawdown of historical surpluses for those CCGs who have them. So I'd be grateful for the approval of the board in due course to proceed with the establishment of the 400 million fund with that particular set of rules to apply to it. Moving on to the newly rechristened Provider Sustainability Fund, previously known, I think rather inaccurately, as the Sustainability and Transformation Fund, or STF. Our proposal is to increase it by 650 million to 2.45 billion. This is the other part of the measures which Simon mentioned to give effect to the priority we set back in December to deal with the deficit issue. And NHS Improvement has committed to achieving financial balance across the provider sector through the deployment of this additional resource. Given the size of the underlying deficit that they will be exiting this year with, that is a significant challenge, but it is our shared view with NHS Improvement that, taken together with the other measures contained in this package around activity funding and incentives in particular, it is doable. And it will finally enable the provider sector to get back onto an even keel. Subject to final agreement with the Department and Treasury, the core elements of the fund rules are being rolled over, so to trigger a payment, each provider will be required to agree to and then deliver the control total set by NHS Improvement, with 30% of the award additionally dependent on performance against the A&E standard. There is one important refinement for 1819, which is that our most advanced integrated care systems will be operating system control totals, which give them flexibility around both the setting of individual organisational control totals within the nationally stipulated overall control total for their systems at the beginning of the year, and secondly, they'll be offered flexibility to offset in-year underspends and overspends across their systems, self-balancing in-year overspends and underspends, I would stress, in agreement with NHS England and NHS Improvement. And to go with that, we need to adapt the regime which then applies to those integrated systems. So as a consequence, we're proposing for ICSs that at least the additional 650 provider sustainability fund element that I've just been talking about will be dependent not on individual providers' bottom lines, but on system financial performance. And by the way, there will be similar arrangements for any relevant awards to CCGs in those areas under the Commissioner Sustainability Fund. So I think a powerful new incentive to work as a system and to be rewarded for making the system work rather than purely the organisation. For those who want to go one step further, we are also giving ICSs the option, but not the requirement, of making the full Provider Sustainability Fund conditional on system rather than organisational performance, in exchange for a bigger say on performance interventions normally carried out by the relevant national oversight body, and we'll be able to update you in due course as to the response from the sector on that particular option that they have. So again, I'd welcome the board's approval of the increased allocation to the Provider Sustainability Fund and the modifications to the rules of operation which I've set out. Table 2 at paragraph 33 summarises in the first blue column on the right the additional allocations I've described to date, and the remaining ones set out in the paragraphs 26 to 32. I draw your attention in particular to the increased resources for specialised commissioning, which is partly to ensure that we set realistic levels of activity growth in that area, as with CCGs, and partly to deal with the very substantial wave of highly effective but pretty universally very expensive new drugs, which have either recently been approved by NICE and therefore carry a mandatory funding requirement, or are expected to receive such approval over the course of the next year. I should say that the number would have been significantly higher had it not been for the measures that we've put in place over the last year to secure better value from our work with the pharmaceutical industry. So when we come to it, I'd invite you to approve the full set of allocations set out in Table 2. And finally, there are just a couple of changes to the operation of incentives which I need to draw to your attention. I'm afraid we didn't put this in the allocations paper because they're not strictly allocations, but you can find the detail of this on page 17 of the planning guidance document that was attached, I think, to the board paper. There are a number of changes to the Sequin incentive scheme proposed for 1819, most of which are relatively technical in nature, and I won't go through here, but they're set out in the document. But I would draw your attention to two more significant changes. In paragraph 612 of the planning guidance itself, we propose to suspend temporarily one of the proposed indicators for 1819 and recycle the earning power to the other indicators. We're doing this to support providers in delivering the financial balance requirement I mentioned earlier by making it easier for them to earn Sequin income. And I'd want to reassure the board, because there's an obvious question which follows from withdrawing a Sequin indicator, which is all to do with discharges, that there are plenty of other incentives, and you can think of many of the natural incentives for providers to execute discharges in a disciplined and prompt fashion. So we are confident it's not going to damage the performance improvements that we need for next year, but it will make the incentive scheme rather more straightforward for providers. And the second change, in paragraph 614 of the planning guidance, confirms a second, even more significant way, I think, in which we're supporting providers to meet the financial challenge by withdrawing the requirement for 0.5% of their Sequin to be set aside as a system reserve. And you'll obviously spot that this mirrors the similar release that I mentioned when I talked about the Commissioner position, where we're not requiring Commissioners to set their 0.5% aside either. But again, that will be a significant improvement in the position for providers in terms of the available funding that they've got to deal with the pressures and challenges that they face. So that's the sequin changes that we're making. We're also proposing to restructure and simplify the quality premium for CCGs, mainly to provide a shared incentive for CCGs to work with their providers to control demand for emergency services. So CCGs who meet the the finance and quality gateways, which remain unchanged, will be eligible for their share of £210 million in quality premium if they meet or beat their planned activity levels for specified elements of emergency attendances and admissions, and a further 64 million to make a total of 274 million available under the quality premium scheme will be available for a basket of other performance and quality indicators, which will include general elective and cancer waiting times, as well as some of the key quality improvements that we're seeking to secure. Full guidance on both of those incentives will be published in due course, and we are still working on some of the detail together with NHS Improvement. So we're asking the board today to approve the broad changes that I've just set out and to delegate to the Chief Executive and the Chair of the Commissioning Committee the final sign-off of those schemes in the course of the next few weeks. While we're at the back end of the planning guidance, I just finally draw the board's attention to the timetable on page 18, about which I would make just 3 points. The first is that given that this is an update, as Simon said, to existing 2-year plans, and the kick-off is just a bit later than normal, we are working to a tight timetable, with the first submissions due in a month's time and the entire process wrapped up by the end of April. Secondly, we are seeking to run an integrated process of normal operational planning, if that's not a contradiction in terms, and detailed planning for winter. That might sound like an obvious thing to do, but it's actually not how we've done it in the past, which has frequently led to some risk of confusion as to what costs and income were or weren't included in the operational plans, and an obvious weakness that the most critical capacity planning activities were not generally reflected in the plans that we then use for all of our core monitoring and reporting. So we're running the process at a similar timetables this year to ensure alignment, making it clear that all of the available resources are factored into the allocations that we're making at the start of the year, and we therefore expect operational plans of CCGs and providers to reflect the fact that there are 4 seasons of the year and they have differential characteristics to them, and therefore that they are fully planned in both sets of plans. And thirdly, you'll note the key role for STPs in orchestrating the contracting process for their patches and ensuring that all parties are fully aligned in their assumptions about costs and income. This, I think, will be a major step forward in what has historically been one of the most challenging aspects of the planning process. It puts quite an onus on STPs to work with their CCGs and providers to do that, but I think will be a really big step forward. All in all, we think that the propositions outlined in the board paper and published in the planning guidance give the best chance of success in delivering on the priorities we agreed back in November, with the resources which have been made available by central government. And I look forward to reporting at our next meetings on how the system rises to the challenge. But for now, we'll perhaps stop for questions, observations, suggestions, or contributions of money before we proceed to make the formal decisions that I've outlined.
Well, thank you very much, Paul, and I think the board recognises the enormous amount of work that has gone on since our meeting at the end of November. But let me invite questions or comments from colleagues on the board. David?
So I have 2 questions. First one for Paul. Paul, you mentioned that this will require considerable efficiency improvements and other savings. Can you give me some scale as to the sort of percentage efficiency improvement across the system and how that might compare with what's been delivered in the recent past?
I certainly can, although that will be confirmed obviously through the planning process, but we would anticipate that we'll need at least a similar level of efficiency next year to the one we've delivered this year, which is, as we'll reflect later on, is about 3 billion efficiency, roughly 3% in the commissioning sector, and slightly more than 4% different metrics, so they're not directly comparable in the provider sector. Had we not had the additional money that we have just factored into our decisions, those would have had to be at much more significant levels, and frankly we have stretched the system this year to what feels to me like the maximum extent we could possibly have stretched it to, and that would have been an incredible, in the literal sense, feat of planning.
But I think it's worth drawing that point out, that this is, the fact that there is extra money is great, but the efficiency ask is very substantial. and is materially faster than the productivity improvement is materially faster than the broader economy, which is what the NHS has delivered now for I think 4 years running.
Yes.
3 or 4 years running. So it's important for the board to recognise that, but also recognise that comments about productivity of the NHS versus the broader economy are somewhat misplaced occasionally.
Yeah.
Okay. And a question for Simon, which is, Simon, this is all great. Money is, and allocation is important, but actually it requires the workforce to be a capacity to be able to deliver it. And given that capacity and workforce has been an ongoing conversation in this board and others, and it's stretched, what reassurance can you give us that the capacity will be in place to deliver the goals and the targets that will underpin the financial plan?
Well, hospital capacity is going to be something that NHS Improvement with our teams locally are going to be looking at very carefully when providers submit their plans for next year and connect that with the agreed extra emergency and elective activity that they're being asked to deliver. If there's a small sort of break in the clouds on that point, I suppose it's that actually the growth in inpatient bed days has been moderating. So inpatient bed days are up 0.7% year to date and are about flat on a sort of rolling 12-month basis. So yes, there are big pressures in hospital staffing, but that's been accommodated within, broadly speaking, a kind of steady state need for or use of inpatient staff. But I don't want to underestimate the pressures there, and Jane might want to talk specifically about some of the nursing pressures that we think are very real. For the key priorities that we've set for primary care, for mental health, for cancer, as you know, we have dedicated workforce plans linked to HEE for each of those. For primary care, the real story for 18-19 is going to be getting the extra GP international recruits online that are being targeted. 600 extra staff internationally is the goal that's been set there, and then another 500 clinical pharmacists and mental health therapists as well embedded in primary care. So there's a kind of plan, Arvind, Madden and the team kind of driving that, but that's obviously crucial. On ditto on cancer. On mental health, what I would say is that I think it's pretty clear that even having implemented by 2020 the mental health task force, we will have made a good first step on addressing the massive service gaps that exist across mental health services, but clearly that's not going to be the end of the story, and therefore there's no case for waiting till funding decisions are made for the period 2020 to 2025 before going ahead with as big an expansion of the mental health workforce as we possibly can. So we will be advocating that HEE, in the workforce plan that they will be concluding in June, essentially go all guns blazing on further expansions in mental health training over the next 5 years, because we're going to need those people come what may.
Okay. Jane, would you like to elaborate on the nursing workforce pressures?
Yes, absolutely. So I think the board will be well aware that there are significant pressures with registered nurses and midwives at the moment. The number of vacancies varies, but it's in the region of around 36 to 40,000 at the moment. A significant number of those are filled by bank or agency staff, but that does have an impact in terms of continuity of care and quality and support in some cases. I think we've got a couple of really significant issues. One of them is being able to recruit enough staff. The latest UCAS data that was published at the beginning of this week showed that the number of people applying for undergraduate training had reduced again, so 13% reduction in England. That's on top of a 20+ reduction in 2017. So that looks like we're in the region of around 30 up to 39% reduction in number of people applying. That may still be, on aggregate level, higher than the number of university places, but what we haven't got and what we need to understand is how that looks across geography, different parts of the country having different impact, and also, of course, branches of nursing. And we know from last year that slightly older people that go into nursing, which are often in mental health and learning disability, were disproportionately affected. So there are some real concerns around that. The other aspect is around retaining the staff we've got. The retention figures and the turnover is higher than it has been. NHS Improvement are leading work on retention collaboratives, done some really good stuff across the country. They're working with every single mental health trust at the moment and targeting those acute trusts, for example, where there are significant issues. But staff are working under enormous pressure, and their work-life balance is something that actually is meaning that several are choosing to go and do something else or go and work for bank or agency. So it's a massive piece of work around not only being really clear about the benefit of graduate nursing and midwifery has, what does it mean to patient outcomes, encouraging people to stay in the job, making sure that we give them the work-life balance that they need to be able to do a good job and feel valued. So part of the work I'm leading is around improving the perception and image of nursing, working with NHS Improvement around how can we actually ensure that they have the best possible work-life balance and that they are respected and valued for what they do, and I think that's absolutely critical.
Thank you. Other issues? Yes, please, John.
Paul, can I just... You briefly mentioned system control totals, which is obviously a very important step in the direction of place-based commissioning. An awful lot of the upcoming integrated care systems will have boundaries that aren't coterminous, so mental health trusts and CCGs and so on. How advanced is the planning and working out which patch an ICS covers and which patch the control total covers? Because there will be organisations that are sort of partly in and partly out potentially.
Yeah. So we've developed this initially as part of the STP process, which was, a year and a half ago now, I suppose, wasn't it? So yeah, in some places it's relatively straightforward. In some places, as you say, it's incredibly unstraightforward, if there's such an expression. So we've got, if you like, a standard approach, which is some agreed percentages of organisations that split themselves across 2 or 3 things. We take completely out, generally, those organisations which are so scattered as to be a little bit in every possible STP. But generally speaking, we've got a fairly stable version of that. And as we've been going into ICSs, they have kind of redefined what those are. Most of them are, I think most of them are still STPs. There are a few which are smaller subsections where we've had to make allowance for that. So I don't think this is something we need to worry about. We've got a default position, which is what we did in STPs. Clearly, as we define more ICSs, they may require some adaptation, but we've got a fairly well-rehearsed way of combining bits and pieces as necessary.
Other questions, comments for Paul and Simon? No? In which case, first of all, I think to thank those two and the team for what's been a very complex piece of work. The board has been engaged throughout in the process of producing the planning guidance, and we were able to publish that last week, for which many thanks again. A great deal of work has gone into not only developing that, but developing it jointly with NHS Improvement. I think has been a major and commendable piece of work. Secondly, we therefore need to note the publication of planning guidance, and then thirdly, because these decisions involve an enormous allocations of sums of money, I'd just like to take the board through each of the decisions in turn that we're being asked to make. The first of them is to the release of the CCG system reserve and the allocation of 600 million to the CCG through the CCG allocation. So we content to approve that. Secondly, to establish the Commissioner Sustainability Fund in accordance with the rules that Paul has outlined to us. We're content with that. Thirdly, in relation, I've lost count, but whichever the next number is.
It's only the finance payment.
Others are better at numbers than I am, but we don't think we need to get your approval for the formal renaming of the to the Provider Sustainability Fund, but we do need to ask you to approve the expansion of the fund and to delegate the allocation and release of the specific amounts to individual trusts to the Chief Executive and the CFO in partnership with NHS Improvement, Department of Health and Social Care and her Treasury. And we're content to do that. And then the last one, Paul, is the full set of allocations in the table at the end. with the assurance that Paul has given us in relation to variations in the sequin indicators and also with the quality premium. And with final sign-off, Paul, you're asking to be approved by the Chief Executive and the Chair of Commissioning Committee.
For the two incentive changes, that's what we need to do. The allocations in the table, I think we are settled on, and therefore they can be approved.
They can be approved today. So are colleagues content with all of those approvals? I think we are. Thank you all very much.
Excellent. I didn't get any bids yet for the prize, but maybe you can tell me afterwards. It is in Appendix A if you want something to do for the rest of the meeting.
Wendy and I have found it.
Excellent, right.
Please, I don't want any further distraction of
content
attention
growth, yeah.
from the business in hand, but congratulations.
David
Right.
found it too, he just doesn't acknowledge it.
Well, right, I would like us to move, if we may, to the progress report from the Empowering People and Communities Taskforce. First of all, just to apologise that Victor isn't with us, and Victor has, I think, very capably chaired this task force. But in his absence, we're joined now by Neil Churchill. Neil, welcome, who's the director who's been most closely associated with the programme. And we also have Michelle with us, who has been a member of the task force. So I'm sure that we will be able, never could we make up for the absence of Victor, but we'll do our best under the conditions that we've got. So who will kick off for us in the introduction to the paper? Would it be you, Jane?
So I'll just say, I'll be
Please.
very, very quick and hand over to Neil and Michelle. I think what we really wanted to bring today is a paper that actually just really shows what we are doing to make sure that we've got genuine patient and public participation. It's absolutely critical to our very business and to doing the work that we are here to deliver. And I think this task force, this new task force, has really shifted the way in which we address that really critical fact. So I just wanted to set the scene very, very briefly, because I think it's probably important that we hear from both Neil and Michelle, because they'll be able to give you more of the detail. Sure, do you want to start?
Okay. Well, just to add briefly that there have been very high levels of engagement with patients, public and voluntary sector in developing strategies, and things like the Independent Task Force on Cancer and Mental Health were real exemplars. What we wanted to make sure is, as we move into the delivery phase, that we have equally strong ways of involving people in achieving the ends. And I think the idea is that this will help us both to achieve insight about what's working and what we need to do more of, but also help us to enlist the support fully of the voluntary sector, of NHS volunteers, of community groups, patients and public in delivering what are a very high set of ambitions. And so what we're trying to do is to make sure that all of the lessons that we've learned from both the strategic phase and for what's working in delivery are shared and spread, to making us as effective as possible.
Okay.
Sure.
Just to add, firstly, a thank you to the many patients, citizens, carers, family members and clinicians who've taken part in the first session, which we looked at the cancer strategy, and we had a Twitter debate about that. So very, very thankful for the time that people have put in to sharing their experiences, but also thank you to the task force members who are very committed to this programme. And I think we as a board, the task force members and many people watching today hold a belief and a commitment very dearly, and that is exactly that the involvement and engagement of communities and patients and citizens is absolutely essential if we're going to achieve many of those ambitious goals that have been set out in the 5-year forward view and the next steps document. We have 3 core components of our work. Firstly, on people, so looking at population engagement, participation, co-production, and how this can help improve future delivery of services. Second is around patients, so really actively using the insights from patients, carers, to drive quality and improve outcomes. And the third, an important area, is how we partner with the voluntary community sector to add value to future service delivery, but really importantly, add value to the 5-year forward view. So as Neil and Jane said, this is absolutely about how we learn, adapt and improve to ensure that we deliver better outcomes for people today and tomorrow. So a couple of things that we've been doing as a task force, one of which is developing, as the paper says, quite an innovative dashboard looking at how well we're doing on public participation and engagement. Now that is a work in progress at the moment, but it begins to help us have a collective view of how well we're doing as a system, and also gives us some very important insights about the areas that we would need to improve. And as you first develop your insight, there's obvious areas to celebrate and obvious areas for improvement, and I think we'll be looking at that closely. You'll see from the board paper that the suggestion here to the board is that we commit to publishing that dashboard as in July as part of our overall publication of the annual report, and I think that might be a very, very helpful tool for the board. The second is to really perhaps draw attention to the first session we had on the cancer programme, and we want to ensure that we have a focus on inequalities and that we ensure seldom heard voices are brought to the table. And so with that, the task force focused on one of the most important programmes we had, which is, of course, the Cancer Strategy programme. Very impressed with the overall ambition of that programme, the progress that's being made, the introduction of the quality of life metric, which is world leading, but also wanted to draw attention to a number of factors, one of which was the focus and discussion about groups that are potentially being left behind. So we particularly wanted to raise some issues about the clinical outcomes of certain groups, particularly BME groups and younger people. And Callie Palmer, the director of that programme, will be writing back to the task force about her plans to address that issue. She'll also be writing back to us to particularly say, what's the best ways of involving citizens, patients and communities in the cancer alliances, so that we ensure that great work that was done around the strategy development process continues as we implement these important plans. So a brief update for you on the dashboard and how that can bring insight to us and help us understanding how well we're doing and where we need to improve. And secondly, bringing to life some important questions about a great programme on cancer, but with particular attention on where we may need to improve for BME groups in particular, and continued involvement and patients and communities in the Cancer Alliance programme. And I'm particularly interested, Simon, if you've got any reflections on that point, BME communities in the cancer programme and health inequalities more broadly. Yeah. Yeah.
Okay. Well, first of all, thank you, Michelle and Victor and Neil, for this brilliant piece of work. We discussed with the cancer programme since you formulated this first set of recommendations, and I think since we last met as a board, ONS have published the inequalities in cancer survival data, the most recent data, and what that shows is that the inequality in one-year cancer survival rates has halved since 2000, but that nevertheless there is still a big inequality for the big cancers that we are particularly concerned about. 14.5% difference in one-year survival rate for lung cancer, a 26.5% survival difference for colorectal cancer. So tackling inequalities in cancer outcomes will be the single biggest thing that will drive the overall improvement in cancer survival that we are looking for on the back of the cancer strategy. So what we're asking the cancer programme to do is use their national investments to target particular parts of the country and groups who are losing out, particularly getting late diagnosis, and they will come back to the board with a proposal, for example, around targeting the expansion of colorectal cancer screening, the FIT programme, at those areas with the worst early diagnosis and survival rates, and the expansion of the pilot programme for low-dose CT screening scans in supermarket car parks, as has been tested in Manchester in high prevalence areas at groups who are otherwise missing out, and other aspects of the programme as well. So they will come back to us with concrete proposals for national targeted action. In addition to that, as part of the sign-off of CCG plans for 18-19, we are breaking down the aggregate improvement we want to see nationally into the faster improvement we want to see in those parts of the country and for those groups who are doing worst. But over and above the cancer programme particularly, I'd just mention two other things that we are going to kick off and I think bring back to the board a paper probably at the end of March. One is that you will have seen the disturbing data that Michael Marmot and PHE have recently published, showing that in some parts of the country there's actually been a fall in life expectancy by a year or more since 2011, particularly affecting post-industrial towns and isolated rural areas. So we are going to be doing a joint piece of work with PHE, really understanding the sort of layers of causation there. And then secondly, want to connect that to a review which we're going to conduct of how CCGs are using the extra money we give them to take account of inequalities. And you'll remember that obviously one of the big tools at our disposal is the resource allocation formula for moving money around different parts of the NHS, which has been refined in various ways since 1976 when it was first kicked off. We move about 10% of CCG money over and above what the formula would predict is needed based on inequalities. We move another 5% of specialised commissioning based on inequalities, and we move 15% of primary care funding based on inequalities. The net effect of all of that is that about £1.9 billion of money is being targeted at parts of the country with the worst health inequalities. And the question is, how is that money being used? For the 10 most deprived CCGs, they're getting an extra 200 million for inequalities. And we want to connect that resource flow with the sort of actions that we think that would deal with the life expectancy questions that are arising and the kind of gaps that you describe in the Communities Taskforce.
I think that's extremely positive, and thank you for that, Simon. And I would just reiterate, in conclusion, we'll be using a similar methodology as we look to other issues in the near future, one of which is around patient insight and experience and how we can use the full potential of that in our national programmes, and also looking at how we work together well with the voluntary sector to give you a sense of how the programme will plan out over what is a 12-month period that we'll be operating as a task force. So very happy to take any questions.
Right, thanks. Well, Michelle, Jane and Neil, let me invite the board to direct any questions to you. I have Noel and Wendy. Noel?
It's a tremendous piece of work, and I understand completely why you focused on cancer in the early stage of the project. But we all know there's huge appetite amongst a range of national voluntary organisations to get a better steer on how we should develop partnerships between the NHS in delivering elements, particularly for elderly and frail, and particularly for those with cognitive decline and elderly and frail. So in your next step of work, do you imagine you're going to come up, when you address the corporate priority areas for NHS England, with proposals that would give voluntary organisations that focus on elderly and frail a particular steer on what the next evolution of the partnership should be?
Neil, do you want to?
I think we will. I think the way that will come about will be to look at what some of the integrated care systems have started to do in some of this space, which has been quite ambitious, has been quite exciting. We're going to take a report to the next task force meeting describing some of it. In addition, looking at ways in which the voluntary sector have been involved in parts of it. So I think we're still learning about what those systems are doing differently. But they are doing some very exciting things. We think there's a lot of national learning, and I'm sure there will be recommendations that we'll be making to the task force about how we can build on that at a national level and encourage more of it to happen at a local level more speedily. But it is an exciting area.
Wendy?
Yeah, I mean, I thought it was a tremendous report, and it was a shocking report, actually, especially on some of the findings. So I really appreciate you bringing that to our attention. And I guess one of the things I wondered was, as you start to think about the end products of your committee or your task force, will we be clear on the processes so people can raise issues like the prosthetic issue and the wig issue and things like that that are in the report? Because I would hate to think any of our citizens would ever feel like that. Is that an end goal, that we'll have processes in place on a broader range of issues?
Do you want to talk about the broader patient experience survey thing?
Yes, I think it will. I think we need to look at how the work of the task force becomes business as usual. And we want to make sure that in each of the national programmes we have mechanisms for doing this. I think some areas it's quite strong. So we look at cancer. We have some fantastic data from people with cancer, and about 2/3 of all people with a cancer diagnosis take part in the Cancer Patient Experience Survey, so we know an awful lot. On the other hand, there are some areas in relation to parts of mental health, for example, where we've got pretty weak data about people's experiences, and we've been trying to look at how we might strengthen those. But one of the objectives of the programme is to make sure that business as usual becomes as robust as it can be, and I know Victor is keen to discuss at our next meeting how the board is cited on some of that data and how we're linking it into decisions that you're making. So we are very much looking at that.
Yeah, just to add to, and we are absolutely not suggesting that in 12 months it stops, in the sense that the task force might stop or it might change, but what we are thinking about is how does this become something that is done everywhere all of the time with the right, so people know what systems, what processes, and how to engage and how to express any concerns that they may have got. As Neil's just said, it happens anyway at the moment. We just want to make sure that that's embedded everywhere.
Yes, because doing something outside of because the national programs to some degree almost make it easy, not quite, but how we just embed that is so important for us.
Okay, well, thank you very much. It's I think a tangible reminder that right from the creation of NHS England, we were obliged to undertake consultation with the patient groups and population who we serve. But that duty is set relatively low in Section 13Q, albeit it's a tripwire. I think what we learned from the task force report is how far we need to go beyond compliance in order to satisfy our other overall objective, which is to see how we can narrow the inequalities gap and how we can better match our services to the needs of the population as a whole. So I think you've got a sense from around the board table of how much people appreciate the work that's gone into this and the learning that we have from it. You're asking us, I think, to endorse the proposal to publish the dashboard on an annual basis, starting in July alongside our annual report. Board happy to accept that, confirm that. Thank you. The recommendations on the future work plan, which I think are clearly taking us in the right direction, and picks up the point that Noel has raised about working with voluntary and community organisations. And then thirdly, bringing papers to us which will be accompanied with a statement about how 13Q+++ has been considered in the preparation of the paper. We need to think about, well, what are the relevant papers?
Where appropriate.
We can work that through, but I would hope that the board would also endorse that proposal. I think we're content, so thank you, and thank you again, Neil, and your team for the support you've given to the task force. Good. Well, we'll move on then, please, to item 6 on the agenda, which is the lessons learned from the WannaCry Ransomware Cyber Attack review. And on this occasion, Will Smart is going to join us at the table. And I think Matthew will introduce the paper. Matthew, is that right?
Yes, thank you, Chairman. I shall speak to it for a bit, and then the board can ask questions, and when they get hard, I will ask Will to answer them, if that's okay.
Of course.
So as the board will know, on Friday the 12th of May 2017, there was a global ransomware attack known as WannaCry, which hit many countries and many industries, and hit, as part of that, hit the NHS. The NHS Digital notified the Department of Health and Social Care at 1 o'clock on that Friday afternoon, and I called a major incident at 4 o'clock, which lasted for a week and was stood down on the 19th of May. The NHS responded, as it always does to major incidents, extremely well. There were no reports of harm to patient or patient data being compromised or patient data being stolen. But 80 out of the 238 trusts were affected. 595 out of the 7,454 GP practices, that's about 80%, were infected, and about 1% of the NHS's activity was disrupted over that period. Our major incident team coordinated the response, which included NHS Digital, NHS Improvement, NHS England's national and regional teams, the CSU, NHS staff across the country, and the Department of Health and Social Care. And over that week, we largely cleaned up the NHS and brought running the NHS back on to running on track. Following the incident, the Department of Health and Social Care's Data Security Leadership Board commissioned Will as the National CIO for Health and Social Care to conduct a review to look for lessons and make recommendations, and that report was published on the 2nd of February and was discussed at the PAC earlier this week. Following the attack, immediately following the attack, we identified and prioritised £21 million worth of funding to improve cyber resilience for our major trauma units and ambulance trusts. We have also this year identified another £25 million to put into critical infrastructure, and out of other IT programmes we have identified another £150 million for the next 3 years starting next year for critical investment. The report makes 22 recommendations. 15 of them address the NHS's preparedness. So how secure are we? How well prepared are we? Both in technical terms and in understanding terms, is the NHS prepared for the future? 7 of them address improving our ability to respond if and when there is another attack. Within those recommendations included that every NHS board should have an executive director with responsibility for data security, that boards should have annual cyber awareness training, that we need to make sure we do appropriate training for all of our staff. We need to enhance NHS Digital's ability to monitor the NHS and respond to incidents. And we need to enhance the way in which we support the network of GPs and pharmacy and other elements that are across the network of the NHS when there is an attack, and be able to reach out to every GP practice. In conclusion, Will said in his report, it's not if there's going to be another attack, but when there is another attack. So we need to be prepared for that. Good cyber security is about more than the technology. This isn't an IT project. This is about all of our people. It requires people at all levels to understand the nature of the threat. It needs engaged boards. It needs clinical and operational leadership. It needs strong operational processes and an ability to both prevent and respond. The NHS responded well to the attack last time around, but there are things that we can and must learn from that, and this report, I think, addresses those and puts in place a programme. But it'd be wrong to end without thanking the NHS staff across the country who worked through that weekend and through the week that followed to protect patients and get the NHS back running in the way that we hope it would. So we're very happy to take questions.
Shall we invite Will to comment further?
I think Matthew did an exemplary job of summing up. The purpose of the report was to try and draw a line under all of the reviews that we've had to try and say, where do we go next? And I think we have tried to address issues around standards and leadership, and I think those probably are critical in terms of the next steps.
Okay, thank you. Right, let me invite comments, questions from the board.
No? With your agreement, can I just make 3 points from NHS Digital standpoint on this? Firstly, NHS Digital is very supportive of what Will has done. It's been an incredibly inclusive and extensive process. And I think we've been particularly pleased on the clarity that it brings to the roles and responsibilities of NHS Digital. It gives us a very helpful mandate to be more proactive in areas where we were historically less proactive. And it also gives us a sense of a strong convening of a whole system response, which I think is a major step forward. Secondly, we're getting on with a range of actions which are well described here, including the appointment of a CISO for the system as a whole, a Chief Information Security Officer, which will be appointed within NHS Digital, but will be acting on behalf of the system as a whole, which is a major step forward in helping us oversee some of the implementation and actions that are described here. And thirdly, I think it is a big step forward in giving us a robust plan and structure which allows all parts of the system under the aegis of NHS England, but also under the aegis of other ALBs, to be able to develop an effective response over the next 12 to 24 months. So we're behind it, we're very supportive, and we're getting on with it, and Will has given us very strong leadership to take big steps forward.
David.
So, Will, I think we've talked before. I think it's good, really good initiatives. I think the focus on the people and leadership aspects are, as you rightly point out, more important in lots of respects than the technology aspects. I think the thing that I guess I'm sort of somewhat concerned about is that, you know, cyber is about the cyber criminals find the weakest point in the system and exploit it, and this requires, for all that you can do centrally, a fundamental system-wide response to get, if you like, to lift all boats. And therefore I'm interested in your sense as to the extent to which the system has got the message that individual boards, including this board and others, are taking it sufficiently seriously in terms of prioritisation of activity, of understanding, of leadership, and the process by which you will centrally be able to determine where the weak spots are, and hence our ability to intervene as appropriate, both here, across all the different parties. So a broad question, but essentially around how can we be assured the system as a whole is responding so as that we don't get caught out by somebody not fulfilling their responsibilities.
So I think you're absolutely right, and we're well aware that we're only as strong as our weakest link in everything that we do in the NHS. One of the things that we are doing is undertaking independent assessments of every NHS organisation to assess their compliance against the Cyber Essentials Plus. Yes, so we are currently through 200 organisations at this point. And with NHS Digital, we have another 25 slots that we've made available between now and the end of this financial year. So the purpose of those assessments, whilst there is clearly a very high bar, you pass the assessment when you have met every single criteria that we set. And as yet, so the high bar is about helping us identify where the weaknesses sit, and then working with those local organisations to identify their action plans, and then helping us identify where our investment from the centre could be most appropriately put, on the basis we've done with the major trauma centre. So we have a process, and over time we will have seen every organisation. So I think that's the first thing. We've also put in place, and one of the, I think, reasonable criticisms that was made at the time of WannaCry was we had no visibility of the steps that were being taken locally when the threat was identified and when the patches were released. Again, with NHS Digital colleagues, we've now got a process in place where every secondary care organisation, every CSU, every CCG will inform us within 48 hours that they have a plan to address that vulnerability. So we now begin to have a mechanism to assure ourselves that steps are being taken. So I think that's the second area. Probably finally, from a national perspective, we have sent out for this year a statement of requirements to every board, asking boards against a set of standards to assure themselves that they are A, aware of the threat, and B, addressing it. Which we will of course see. We're working with NHS Improvement colleagues around how we embed that within NHS Improvement's assurance processes, and the Care Quality Commission, as part of their ongoing inspection process, now have cyber as part of the well-led framework. So I think we have many of the tools that we need that we are now beginning to use. I think my final point, going back to your first, is how confident are we that boards and executives are really engaged with this? I've not spoken to every chief executive or every chairman across the NHS, but those that I have done, this is something that they would say they're taking very seriously and is top of the agenda.
And your coverage extends to national bodies. I'm always conscious that we tend to look to the rest of the system when sometimes we need to look at our own.
Yes.
So that would extend to national bodies and also through them to GP practices.
Yes, so the Data Security Leadership Board that commissioned the report, all of the ALBs are represented within that group around this agenda.
Thank you.
I'd just say that I think, just to add that, I think your question is exactly the right one. Whilst we are, as part of this programme, putting in, through NHS, the ability to close the loop when guidance goes out, getting better visibility that's actually been implemented, this is not something you can run nationally. This is a responsibility for every GP practice, every CCG board, every community trust board, every mental health trust board, every acute trust board. They need to take this seriously. It's part of their obligations, like managing the quality of care in their organisations. And this report, I think, as much as saying what needs to be done nationally and how we need to enable NHS Digital to be able to lead on that, is also saying this is part of the responsibility of every board across the country.
Including every ALB board.
Including every ALB board.
Steve.
Thank you, Will and Matthew. So I should start off by echoing what Matthew said in terms of the response that staff gave to the incident last year to minimise the effects on patients and to recover the system as quickly as possible. I think it's really important we acknowledge that. I just wanted a comment and a question referring to paragraph 433 of the report. This is around the Digital Academy. So one of the things I think that we've been a bit behind on is in building a cadre of digital leaders within NHS organisations, and I think the Digital Academy and the work that's going on there will start to generate that resource, and it's much needed. So my huge support for that. But the question is, have you considered how that specific resource might be used to bolster recommendation 14, which is around the people element and the cultural elements of ensuring that we guard against cyber attacks?
So I think, thank you for mentioning the Digital Academy. We have just selected our first cohort, and the Digital Academy will have both clinical and non-clinical staff represented within it. So that's an opportunity to address the technical versus clinical risk issue that we know that we face within local organisations, and getting that dialogue going. Cyber security is one of the key, or is a core part of the curriculum that the Digital Academy will be addressing. So again, we can get coherent messages and strong messages out through that group. These staff will be from across the NHS, so again, embedding that knowledge back into local organisations, communities. So I think the Digital Academy is going to be a really important mechanism, and again, one that I think is taking cybersecurity that step forward to, in terms of the actions and steps that tangibly need to be taken.
Thank you.
I mean, this was a really serious attack, but it was quite fragmented in its impact due to the various vulnerabilities that you've mentioned. I mean, one of the things that stood out for me was the resilience of the spine. Had that been penetrated or had infection spread back into the spine, then we would be in a very difficult position. What assurance can you give us about the continuing investment in the preserving and enhancing the resilience of the spine?
Noel may want to say a few words on this as well. So we continue to invest through the PHC 2020 programme in national resources such as Spine and NHS Mail. So we will continue to invest in those components. We're increasing the investment that we're making within NHS Digital around their cybersecurity expertise and the resources they have to support the system as a whole, nationally and locally. So I think we can give you assurance that we're taking it very seriously. NHS Digital, I think, I know, have been leading lights in government in terms of stepping up, being one of only two cyber essential organisations that give out cyber certs, so kind of the certificates They work very closely with NCSC. So I think we should recognise that we've got a unique resource within the NHS, and one that should give us some confidence that whilst we will not get everything right, we have an organisation that is able to help us as much as any other part of government, if not more.
Well, the first wave of the investment is going into our Central Cyber Operations Centre, which will take an immediate upgrade to both its tools, its capabilities, and the way in which we communicate with the rest of the system. The second wave is going to be to increase the way in which we oversee the readiness of the whole system, and particularly where the assets are, how ready the assets are, how fast they're being patched, how well they're being upgraded, which will be a second major plank of the infrastructure. And then thirdly, to invest in our ability to communicate with the system differently, which was, as we learned, hard to do last time round. And some basic things you might imagine we should have, like telephone numbers, are not yet centrally recorded in the right place, so there's quite a lot of work to do to basically put us in good shape, but we're getting on with those three investments immediately.
Right, well, thank you very much. This will happen again. You've given us that reassurance, thank you. So this board is actively engaged in this agenda and takes its responsibilities very seriously. So I think we will welcome further updates over the next year or two. And I think from today's report, and certainly will from your report, we can take quite a lot of reassurance as to the steps that have been taken in the first wake-up call that we've had. But thank you very much for that presentation and for your report. May we then move on? Just before we do, I just need to note for the benefit of the non-executives that there has been a letter to the system from Ian Andrews and Jerry Murphy about cyber security and responsibilities. We put it in the reading room on board pad so that we've brought it to the attention of our non-executive directors, but it's intended across the system as a whole. Right. We're going to move now on to item 7 of the agenda, which is around NHS performance and progress on the implementation of the next steps. Matthew, may I invite you to kick us off, please?
Thank you. As Simon mentioned, at 9:30 we had the updated stats came out for the NHS, so I think it's probably more useful if I speak to those rather than the ones that are in the pack. And there's been some updated data put on online for both board members and for people who are accessing these board papers through the web. So we start with A&E, and it's always unfortunate when you follow your chief executive and you've shown him what you're going to say, because he pulls the best lines out and uses them. But that's leadership, yes. But we should start with A&E, because we all know the enormous pressure that hospitals have been under, that our A&E departments have been under, that primary care has been under, the pressure that winter brings to bear on the system. A&E improved in December to from December to 85.3% in January, so that's better than we were last December and better than we were in January last year, which in the context of the pressures that the NHS has been under with flu, I think is an impressive performance, although well short of what our aspirations were for winter and what they are for the NHS as a whole. I think the reason we end up where we are is because significant parts of the urgent and emergency care plan led by Pauline Phillips have been implemented across the country and have made a big impact. So delayed transfers of care, we've now are showing at the end of December that we've released 1,957 beds, so we've got 4,688 beds currently blocked by delayed transfers of care across the NHS, but that's an improvement of 491 beds on the position in November. This is a better detox position than December 2016 or December 2015, and it's close to the position of December 2014, and in terms of NHS delayed transfers of care, it's our best position for 4 years. So we effectively managed to release 2,000 additional beds back into the system through that, which we had aimed to do in order to be able to improve our performance back up towards 90% across winter. The excess pressure of flu meant that we had about 3,000 additional patients with flu in hospital across the winter period. So those delayed transfers of care, I think, were what stopped the NHS from getting into deeper trouble and actually allowed us to maintain performance across December. That, along with the fact that I think hospitals worked hard, primary care worked hard, many pieces of the system fell into place in order to keep the show on the road. So other things that we did within, that we've been doing in terms of implementing the urgent emergency care plan, including we now have primary care streaming in 90% of our Type 1 A&E departments. 111 took 100,000 more calls in January 2018 than it did in January 2017, and has taken 750,000 more calls in the year to date than previously. And the number of those calls that had clinical input into them was up to very nearly 40% compared to just under 25% a year ago. So in terms of the ability of 111 as a telephone-based service to be able to relieve pressure, it's done a very good job. In looking at the activity that has gone through, non-elective activity is up by 3.1% for admissions year to date. That is better than the provider plan position, which was expecting a growth of 3.3%. It's also worth noting that those non-elective admissions represented a 7.3% increase in the zero length of stay admissions, so patients who were managed in the A&E department and associated services, and only a 1.3% increase in the over 1 day length of stay, admissions. A&E attendances were up by year to date 0.7%. Against provider plans of expected 3.4%. So we've done a tremendous job through the urgent emergency care strategy, keeping patients who don't need to come to A&E away from A&E, so that the weighted admissions into hospital are up by 2.2% overall against the expectation of 3.2% overall. And total bed day growth, as Simon mentioned, there's been an increase in bed usage of 0.7% during the year, and actually a 0.1% reduction on the 12-month rolling average of bed usage. So I think the signs that the system pulling together here to try and deal with capacity constraints and deal with the pressures have kept the show on the road through December and into January, and I think it's a tribute to the whole of the system that has been achieved, and I'm grateful for that. In terms of waiting lists, we've seen waiting list activity 2% higher than last year in December, but that reflects a 4% reduction in admitted elective work in December, and a 4.2% increase in non-admitted elective work, which I think is a reflection of the pressure on hospital capacity. Waiting lists, we were at 88.2% against our RTT target, and again, really good signs of the system pulling together in order to manage patients in the right place and keep people out of hospital who can be better managed in other locations, managed in primary care. GP referrals into hospitals are down by 1.3% year to date, and overall referrals are up by just 0.8%, which reflects actually quite a large increase, 4% growth in consultant-to-consultant referrals in hospital. That was against an expected plan within the provider sector of a 5.9% growth in overall referrals. So I think, again, good signs of the system working together to get patients the right care in the right places, and move away from hospitals being a magnet that attracts everybody, whether they need to be there or not. Our mental health strategy, we're on track for those targets, and cancer, we're hitting most of the targets and moving towards the 62-day target for waiting times, but still work to do there to get to our ambition. So as we look forward to next year, it's key that our plans for activity are realistic. As we've said in the planning guidance, we want every part of the system to feel signed up and committed to the fact that the money that we've put into, the extra 650 million we've put in for provider deficits on top of the 1.8 billion that's there, the 400 million that's been put into commissioning deficits, means that this year's work can be properly funded to be delivered at a high quality next year, and we've funded the growth in emergency activity at what we've been seeing this year, and a growth in elective activity that should allow us to stop waiting lists from getting longer. So there is money there is the money in the system to be able to improve performance, providing the NHS continues the work it's done this year in terms of managing demand and managing productivity. And it's been a tremendous effort to do that this year, and we need to do the same tremendous effort again next year. But I'm confident that as we're making the variety of changes around creating more integrated systems across the NHS, we have the right people having the right conversations in order to be able to continue to drive that progress.
Matthew, thanks very much. Let me invite comments, questions from members of the board. No, I think your report's taken as read. Thank you for that.
Thank
and
you
actually
very
for the
much.
very reassuring figures that Simon referred to earlier, and which you've touched on as well, which come from the activity data published this morning. Right then, on that basis, we move now to the NHS Finance Report. I'm going to invite Paul to present the paper, please.
Okay, thank you, Malcolm. I'll keep my comments on the in-year financial position brief, because in essence the report you have in front of you confirms the trends I discussed at rather greater length at our November meeting. I'd also say that the Commissioning Committee spent a fair bit of time yesterday reviewing the position in more detail and was content that all necessary actions were being taken to ensure that the commissioning sector delivered on its financial commitments. As you can see in the numbers in front of you, the headline forecast remains roughly balanced at 18 million on a budget of 110 billion or thereabouts, and the level of risk to delivering that position has halved from 385 million when we met back in November to 189 million as it stands today. That's happened as we've been implementing the strategy we talked about at that meeting to identify non-recurrent savings in NHS England budgets to mitigate the ongoing pressures, in particular in the CCG sector. That process continues, and we remain as a team committed to delivering a break-even position for the commissioning sector. The board will also be aware that this excludes the 560 million of system reserve that we set aside at the beginning of the year and have been guarding very carefully since then. Within that overall position, I'd say the CCG position, which is the major action in all of this, remains largely unchanged. The year-to-date overspend of just over 1% reflects in roughly equal measure the underlying pressures which we've discussed at great length in previous meetings and the more recent specific factors arising from issues in the generic drug market. As I set out in paragraph 5, it seems likely that most of the risks reported by CCGs alongside their core forecast will crystallise, taking the overspend for the year to over 700 million. Within all of that, there is some good news. I have to say, reluctantly as an accountant, of course, we always like to bring the bad news and then reluctantly have the good news winkled out of us at the end, but let me start with the positive. The measures taken by the Department of Health and Social Care to reduce the impact of that short stock issue I referred to in the generics market do appear to be bearing fruit, and the monthly cost has been roughly halved compared to the peak that it reached in October. That was the December number, and the numbers I got this morning for January look as if they've halved again. So we are gradually coming down from a very high number to a rather less high number. It is not yet back to the sorts of levels that we have seen in previous years, so there is still some work to be done, and it's predominantly about the price setting rather than the number of drugs which are in difficulty at the moment. But we'll watch this space. Critically, we need to see where that goes over the next 3 months, clearly, between now and the end of the year. And then, I guess, our expectation is that for next year, we will be less encumbered with that particular completely unforeseen pressure. So that was the good news. Little bit of negative news. We did have some specific deteriorations in a couple of health economies in the Midlands and East in month 9, which clearly the regional team is intervening on rapidly, but the expectation, I'm afraid, is that what they are doing for this year will be fairly limited in mitigating impact, and it's more about now resetting the dial for next year. So even if we cover off the CCG overspend that there will be at the end of the year through one-off savings in other budgets in 17-18, the action I outlined in the earlier item on planning to eliminate the underlying deficit in the CCG position, which is somewhere between 400 and 500 million, hence the size of the CSF that you signed off this morning earlier on. That measure that we're taking is clearly essential if we're going to have a chance of successful financial management in the year ahead. I'll stop there, but am, as always, happy to take suggestions and questions from the team.
Good, thank you, Paul. Let me invite questions, suggestions, comments from around the board table.
Paul, usually at this time we have, in years gone past, shall I say, the specialised commissioning budget has always been sort of a high-risk area. Last year, I think, because of the actions taken, it was a lot more sort of balanced. What's the assessment of risk this year?
I see no risk at all of the specialised budget being overspent this year. There are risks in particular pockets of specialised commissioning. The South in particular had a higher efficiency requirement than the rest of the country. So how that will play through we will see. But mainly due to non-recurrent factors again in specialised, the phasing of when drugs have come on stream in particular, I think we've got adequate cover for specialised.
I've got a slightly left field question to Paul, which really is only peripherally related to his responsibilities. But so
what's new there? What is new there?
Since it appears in your report, Paul, it's relates to a conversation that someone was having earlier today. We are the we passport through £141 million of clinical excellence awards for consultants. And there has been some reporting on this recently, that in the light of the national conversation about whether women are being paid appropriately across many aspects of the economy, there's been reporting to suggest that a relatively small proportion of the high-end clinical excellence awards are applied to and awarded to women. And so, although we don't have direct locus other than doling out 141 million on behalf of decisions that are made by others, I would like, through you, to ask Steve, as our new National Medical Director and our representative, I think, going to be our representative on the national panel, to ensure that as the discussion on the reform of clinical excellence awards now takes place, and the Department of Health has indicated that this will form part of the consultant contractor discussions, that this question of women's access to high-end clinical excellence awards is properly and transparently looked at.
Happy to take that on.
Thank you.
I thought for one awful minute I was about to become both the HR director and the medical director.
Yes. Right, well, thank you.
Thank you for that.
We will record the National Medical Director's consent to taking that forward, but very grateful. It has come up in discussions we've been having in other contexts recently, and it's a very important issue and an opportunity, as Simon says, with the discussions around consultants' contract to start to get to grips with it. Good. Thank you very much. Nothing else on Paul's report? Yes, Wendy.
Yeah, no, I just think the only thing, I guess, to build on this, we did talk about this quite a while yesterday at the commissioning committee, and it does get laid out in such a simple way at this time of the year of everything coming together. But I do think the underlying risk and the complexity of getting to this position, we can never take that for granted. So a degree, it's, thank you to the system, but it's also really wanting to watch very closely as we bring the year to end. So thank you.
Indeed.
Right. Well, thanks very much on that cautionary note. So we're going to turn now to reports from the board committees. We've got some quite full reports from 3 of the committees. So I'll just invite briefly the chairs of those committees whether they've anything to add to the written reports that we've got. David, in respect of commissioning committee.
I think the reports stand as sort of read. I think the only point perhaps is the fit test is an important and very helpful change, and I think it should be seen as a start of the process to in terms of its gradation, and it will continue to develop over time. But I think a very important change in our battle against cancer.
Good. Thank you very much. Any comments on commissioning committee? No? Then may I turn to specialised services. Noel, anything further?
No, Malcolm. The minutes summarise the important agenda that we had last time around, and I don't think they need much more clarification.
Good. Thank you very much. And Joanne, audit and risk?
Maybe just one thing, Malcolm. So colleagues will know that we have a pretty comprehensive programme of internal audit projects and investigations that goes on all year round. And what that programme does is it generates a large number of actions for the teams to carry out to remediate any areas of risk or concern. And at the audit committee before last, we were a bit disappointed that ongoing hard graft to deal with those questions and to put those actions to bed had got a bit behind, and we were very pleased to see that there had been a major effort to catch up, and things had improved a lot. I mean, it just doesn't stop this work, and I suppose I would like to show our appreciation for that pretty unglamorous but important work, and to recognise the effort that goes into it.
Good. Well, thank you very much, Joanne. So may I invite the board to receive those reports and just ask you specifically to ratify the proposal that's come through from the Commissioning Committee report of the meeting on the 15th of December, which is the approval of 15 applications for the formal delegation for the commissioning of primary medical services. Are we content to ratify that? Good. Thank you very much. We move now to any other business. I have no other business. Does anybody else? Any other business? Great, in which case I would ask the board to pass the usual resolution about moving into private session. Thank you, and declare the meeting to be closed. Thank you very much.